Hi, my name is Mark Wright. I'm one of the consultant eye surgeons at the Eye Pavilion and with Edinburgh University, one of the lead tutors there. I'm just going to do a little introduction today on the use of diagnostic algorithms in ophthalmology. I've come up with a few simple diagnostic algorithms for the more commonly encountered eye scenarios such as red eyes, visual loss and double vision. There's another couple of less commonly encountered scenarios such as watery eyes and anisocoria, difference in the pupil sizes, but we're going to concentrate on those three main ones: red eyes, visual loss and double vision. And what we did is we tried to validate the accuracy of these diagnostic algorithms, and we've done three little studies, two of which have been published in Eye and one of which is away at the reviewers. And we'll go through the results of those studies just in the next couple of slides. Why would you might want to introduce diagnostic algorithms? One problem that, for instance, optometry trainees have, and also GPs as well, but especially optometrists, is that there's no substitute for being in a clinic with an experienced clinician for some direct one-to-one teaching. But because there's so much pressure on the NHS service at the moment, it's very difficult for consultants to get time to leave the clinic to do some teaching, or if the teaching's in the clinic, having reduced numbers of patients to accommodate more teaching. So one way of trying to substitute having a second best solution is having these little diagnostic algorithms, which are effectively the written manifestation of the thought processes of more experienced clinicians. And the idea would be that if you're doing some learning before you come in the clinic, then the chances are, if you're understanding the principles of how you start to approach patients presenting with red eyes, visual loss and double vision, then you're effectively hitting the ground running. So when you come into the clinic for your limited attachment, you're likely to get much more benefit out of it because you'll understand what's going on effectively before you get into the clinic. So we'll go and look at some of the algorithms themselves. So the first study we did was on the red eyes, because the red eyes are probably the most common presentation. And you can see here that what we did with this study was we had referrals in from the community with GPs, optometrists, and other hospital doctors. And then what would happen is that we had some inexperienced observers, GPs, again A&E, nurse practitioners, opticians, and then those opticians, GPs, nurse practitioners would use the algorithm to essentially come to an algorithm assisted diagnosis, and then the same patient would then be seen by an experienced clinician. In this study it was a specialist ophthalmological trainee of ST3 or above, very often an associate specialist or even a consultant, and then they would come to their diagnosis, and effectively that would be the gold standard. And what we did was we were looking at what was the degree of concordance, the agreement essentially between inexperienced observers using the red eye algorithm. They would come to their algorithm assisted diagnosis, and we would see how close they came to the gold standard diagnosis. We had some baseline data, not from this study, from other studies in the past, looking at how good were inexperienced clinicians at picking up particular serious red eye conditions. And the most serious red eye condition we see is acute angle closure glaucoma. And you can see from the slide here that only 21% of GPs and 64% of A&E doctors got the correct diagnosis. Similarly for iritis, another serious red eye condition, only 44% of GPs got it correct. Now, when the same inexperienced observers used the diagnostic algorithm, you can see that they got acute angle closure diagnosis correct 100% of the time. Now, these weren't enormous numbers of cases. There was only 39 patients in the study itself, but given the fact there's such a dramatic increase in the diagnostic accuracy, I think it's a reasonable result. It stands on its own without needing to be repeated with larger numbers. And again, simply again for iritis, again with GPs, you can see that the diagnostic rate went from 44% up to 82%. Now again, that's for some doctors that may not have access to a slit lamp. Clearly all trainee ophthalmologists and all optometrists are always going to have a slit lamp there, unless you may be doing a home visit. If you're seeing a patient that's it's a bit infirm and you have to do a home visit to do a glasses test in the patient's home, you may not well have a slit lamp at that point in time. So overall, the accuracy of the red eye algorithm was 72%. Moving on to, in fact, this is just an example of the red eye algorithm. I'm just highlighting now, you can see the first question at the top here is the obvious thing. Is the red eye bilateral? Is it red eyes or is it unilateral? And if we concentrate on the bilateral red eyes to start off with, the way we broke it up was, is the predominant ocular symptom itch, or is it predominantly gritty or burning? If it's itch that's the problem, then again, that's much more likely to be allergic conjunctivitis. Often the patient will have a history of atopy, asthma, eczema, hay fever. Often the discharge will be a little bit on the stringy side as opposed to purulent. I'm not going to chat about the treatment, but that's a useful differentiation. Again, coming back to the symptom, if it's predominantly gritty or burning rather than itching, itchy, then the next question would suggest is useful is asking if there's discharge present. And discharge usually reflects conjunctival irritation. If there is discharge present, it's likely to be infectious conjunctivitis. Again, it's probably very difficult for even the most experienced consultant to differentiate between a viral infectious conjunctivitis versus a bacterial, and I'm not going to say any much more about the treatment there. Again, if the patient has a bilateral red eyes, it's predominantly gritty or burning, and there's no discharge present, then the likely diagnosis is dry eyes. Again, it's a wee bit of a cheat having dry eyes in the red eye algorithm, because patients that have dry eyes, almost inevitably their eyes are either completely white, uninflamed, or only very slightly pink. The reason why we put it in was that almost universally patients that have significantly dry eyes will have, as their main complaint, gritty and burning eyes. So you can see those three diagnoses, allergic conjunctivitis, infectious conjunctivitis and dry eyes, they are always bilateral. Now, I can see some of you will be saying, no, I've definitely seen patients with unilateral infective conjunctivitis, and I'm sure you're right. The classic example of that is a child. About 25% of all children are born with an imperforate nasolacrimal duct. And like anywhere in the body, if the secretions don't drain away, then they get secondarily infected. So the reason why newborns, often the nasolacrimal duct will open up, and the 75% open up spontaneously in the first year of life. So the reason why some young babies get unilateral infective conjunctivitis reflects the fact that they've got the secretions not draining away. Now, unless the patient's got a definite history of long-standing wateriness on that side, then it's a dangerous diagnosis to make of a unilateral infective conjunctivitis, because there's lots more serious things that you might misdiagnose, hence the reason we always say infectious conjunctivitis has to be bilateral. If we look at the other side of the algorithm now, just looking at the unilateral red eyes, one thing that's often not emphasised, and being an oculoplastic surgeon by trade, as well as a general ophthalmologist, you fail to look at the eyelids at your peril. And the most obvious reason why someone might have a red eye is if they've got an entropion, and that's usually for an older person an involutional entropion, with the lid being a little bit lax, and either the lid turns out the way, an ectropion, and that's usually very easy to diagnose in the appearance, or the lid turns in the way and the lashes are scrubbing up against the cornea, hence the reason for the redness. That's usually pretty obvious. What's sometimes a wee bit less obvious is trichiasis. The difference between those two is that for an entropion, the whole lid margins turned in. For trichiasis, it's really just some misdirected lashes. Now that's often the result of badly done lid surgery, hopefully not by me, or for some trauma. Again, although it's not on the algorithm there, the useful thing is always have a little look at the lid margin. A classic example of a patient with a one-sided red eye and a problem in the lids might be a little lesion just up at the lash margin, and the classic thing would be a little white lesion that's got a tiny wee dimple if you've got some magnification, molluscum contagiosum. It's a pox virus, and they're very common, this infection, in children. My kids all got it, and you'll not have a red eye unless the lesion is right up at the lid margin. And then the problem is the lesion is shedding virus into the conjunctival sac, and that's why the eye's red. And sometimes the little white dot is very difficult to see. It's pretty obvious as soon as you start to look for it, but again, if you just jump in and start to look at the eyes and you don't look at the lids, you'll miss it. The next bit of the algorithm is clearly, again, we're on the unilateral red eyes. Are the lashes touching the eye? No. Has the patient got normal eyelid closure? Now, if they don't have normal eyelid closure, that's a facial nerve palsy. Now, sometimes facial nerve palsies are very obvious. The whole half of the face is drooping, and clearly the reason why the patient's got a red eye is they can't close their eyelids properly. If you can't close your eyelids properly, then your cornea starts to dry out, it develops secondary ulceration, and then possibly even secondary infection. But again, if somebody's got a subtle facial nerve palsy, then that could be the reason for the eyes red. So again, nobody can ever blink. If you say, oh, just blink normally, people become very self-conscious and they do special blinks. But just when you're looking at the patient and taking the history, you'll be starting to do the examination. And what often happens in very slow motion is, if I've got my facial nerve palsy on this side, and these are the lids, the palpebral aperture, what happens in slow motion is this one closes completely, but that one only closes half. So the left eye, the upper lid, resurfaces the cornea with tears and opens up again, but the right one doesn't come completely down. The lower third of or half of the cornea is not being lubricated with the tears, and then it develops ulceration. So a subtotal blink is a subtle facial nerve palsy, but that will be the cause of the red eye and the corneal epithelial disturbance, but it's sometimes easy to miss. So always have a think about the lids first. So if we come down here and it's a unilateral red eye, the lashes are not touching the eye, there is normal eyelid closure, the one key thing to do is to use fluorescein staining. So the key message here is anybody that comes in with a one-sided red eye especially, but even a bilateral red eye, but especially a one-sided red eye, the key thing to do is to put fluorescein into the eye. Now, why is that the case? Because again, if we're looking at the algorithm down here, if you have, the cornea can clearly take up stain, and one of the key messages is a clear cornea does not equate to the absence of an epithelial keratitis. Now, I know there's two double negatives in there, and that's never a good idea. However, the main thing to remember is if you're looking at the cornea and it looks clear, you could still have a serious problem with your corneal epithelium, it being absent for whatever reason. It could be, the most common one you might see is a corneal abrasion. Now, usually you'll get a nice history of a child's finger scratching the eye or something, and then it's pretty obvious. Or, for instance, they might be mixing some cement, and a little bit cement dust goes into the eye, and that's a chemical conjunctivitis. But often patients, for instance, with herpes simplex keratitis, with so-called dendritic ulcers, they don't have a prior history of cold sores. Sometimes it can be a recurrent thing with the infection breaking out from the trigeminal ganglion, and sometimes it's a first ever infection. They've just happened to meet somebody who's got some herpes simplex on their finger, they touch their eye, and away you go. So the most important thing is to put fluorescein in. So again, we'll see the corneal stains, and if the cornea is clear, it's an epithelial keratitis. So the treatment of that would be directed at the underlying cause. Again, if we come down the other side of the algorithm here and the cornea is hazy, it's focally hazy, then that's a stromal keratitis. What we mean by stroma is the cornea is like an onion, there's different layers to it. The anterior layer is the epithelium, continually being shed and regenerated in life. The corneal stroma is the thicker layer, just made up of collagen, and it's quite useful. The cornea only has one type of reaction to this kind of problem, which is it goes opaque. Now, when we did our study and we looked at the false or the things that the algorithm got wrong, one of the problems we found was that inexperienced clinicians sometimes have difficulty examining the cornea, both for the presence of corneal staining, but also for the presence of a stromal keratitis with a little white dot. And we think the problem there is, because the cornea is quite a wee structure, you really need a decent bit of lighting and a wee bit of magnification. Again, that's not an issue if you if you have a slit lamp. If you don't have a slit lamp, what we'd recommend using is a handheld ophthalmoscope. A lot of GPs will have ophthalmoscopes or even little magnifiers there, but they won't have a slit lamp. So if you click your ophthalmoscope onto a positive setting, now sometimes they've got red numbers and sometimes they've got black numbers depending on what type you've got, but literally if you look at the cornea and click the dial, and if you're going on to the correct type of dial, the picture will be magnified, and obviously the ophthalmoscope's got illumination. If you're very lucky, your ophthalmoscope will have a blue light on it, and that makes it much more obvious, but even a white light is better than nothing. So there's the corneal staining. If we come to the other side and say there's no corneal staining, the next most useful thing to look at is the pupil sizes. Again, if the pupil is larger on the red eye side, then what we're talking about is acute angle closure glaucoma, and that's the most serious red eye cause. And if people using these algorithms only got one thing right, I'd be happy if the only thing they got right was acute angle closure glaucoma, because that's a potential blinding disease. If you don't get that diagnosis right first time, every time, then sooner or later a patient will permanently lose their vision or part of their vision. Again, if we come down here, so it's a unilateral red eye, there's no lashes touching the eye, there's no corneal staining, and the pupil is smaller or the same size as the other side, then the next useful bit of the history to clarify is there photophobia present? Again, if there is, then the diagnosis is iritis. Again, if you look at the books, what they say is iritis you diagnose with the presence of flare and cells in the anterior chamber. Now that's fine if you've got access to a slit lamp, but if you don't have, then cells and flare is not a useful part of your diagnosis at all, because it's not available to you without a slit lamp. Even if you're an inexperienced person using a slit lamp, an A&E doctor, or a junior optometrist or a junior ophthalmologist, it takes a little while to get the hang of setting up the slit lamp to see that cells and flare. So again, how we would suggest you might diagnose iritis is, first of all, it'll be a unilateral red eye, there'll be no lashes touching, there'll be no staining with corneal with fluorescein, the pupil will be smaller, and they'll be photophobic. And again, if you remember back to the results on the previous slide, you would get the diagnosis right on 82% of the cases, so that's pretty reasonable. Again, if there is no photophobia present, then is the eye painful? Yes, it's scleritis. If the eye is just discomfort, it's episcleritis. And this highlights the great human condition, one person's pains, another person's discomfort. Again, another useful wee thing to differentiate the two might be if, say for instance, it's my right eye that's red and it's the temporal side, I would normally just ask the patient to shut their eyes. I would touch the corresponding area in the unaffected side just to gauge their reaction. Some people don't like their eyes being touched. If they say, well, I can feel you touching that, but it's not sore, and then they say, oh yeah, that's definitely tender, then it's a very soft sign, but it's more likely they'll have iritis. If they have episcleritis, they'll say, well, I can feel you touching, but it's not sore. Again, the other thing that's not on the algorithm, and that's part of clinical acumen, if you like, if the patient that's got this same red eye, exactly the same distribution and exactly the same tenderness, and say it's exactly as sore as the next person, but if the person you're looking at's got, for instance, rheumatoid arthritis, there's quite a high risk of rheumatoid arthritis patients having scleritis rather than episcleritis. And these are the kind of things that are really beyond the algorithm. Again, you'll already notice, for instance, that if we come back just to this diagnosis of stromal keratitis, again, if you've got a little white dot in the cornea, we're saying it's stromal keratitis, and you would refer them in. Again, people who are more experienced, you'll then have another little arm on the algorithm here. If the cornea is focally hazy and the haze is right beside the limbus, in other words, a marginal keratitis, because the treatment of that is completely different with steroids, as opposed to if the white dot in the cornea is a little bit more towards the centre, or again, if the patient's at a particular risk of having an infectious keratitis, such as a contact lens wearer. So all these kind of things are really beyond the algorithm. That's the basic thing. The idea with all these algorithms is once you've understood how a more experienced person thinks, then you effectively you start building on extra little bits to your own personal algorithm. So hopefully it allows you a way in to start to understand how the more experienced person starts to break down the wheat from the chaff, trying to decide how you, in as few steps as possible, how do you try to decide if this person who presents with a red eye or red eyes has got a more serious condition or a relatively benign thing that they could be treating themselves. Again, so if we go on to the visual loss diagnostic algorithm, now again we got a wee bit better at doing the study with this one. So what we did this time was the investigators, we got the referrals in from A&E doctors, optometrists, GPs, and what we did was we looked at that referral and we looked at what the referring clinician's diagnosis was. If again, as often happens in people who are not absolutely certain about things, they'll just say visual loss, please see. So just in terms of the study, we had that as a wrong diagnosis. I don't know what's wrong with the patient quite often, so you know, we're being realistic about these things. Very often you don't know what's wrong with the patient. You get more relaxed as you get more experienced about not knowing exactly what's wrong with the patient. It's all to do with having a feel for what's serious and needs further investigation and what's likely to have a very benign underlying cause, and just accepting and living with a bit of uncertainty, which is definitely a skill you have to learn as you become more of a clinician. So just going back to the study, overall what we were trying to do with the visual loss, and the key thing with approaching a patient with visual loss is it's all to do with placing where the lesion is in the visual pathways. So is the lesion in the eye itself? Is it in the optic nerve? Is it further back in the chiasm, the optic tracts or the optic radiations? That's the key thing. Once you've actually decided where the lesion is, then if it's in the part of the visual pathways you can see directly, and unless you've got a better ophthalmoscope than I have, all I can see is the eye, the retina, the very front part of the optic nerve. I can't see the optic nerve, anything other than the optic nerve head, and further posteriorly. So what you have to do is to infer a posterior visual pathway lesion or a lesion in the posterior part of the optic nerve. And that's really the whole crux of approaching a patient with visual loss. So when we, what would happen then, the patient would come in, be referred, we would see what the diagnosis of the referrer was, and then what we would do is we'd have a variety of 3 types of person in LOT, the Lothian Optometry Teach and Treat. And in LOT, what would happen is we'd have a junior ophthalmologist that was ST2 or below. We'd have some opticians who could be quite experienced. And we had Cameron, our medical student, who was doing his SSC project on, and he only had literally 13 hours of ophthalmology experience. So within the 3 inexperienced clinicians assessing patients, the same patient is referred in, we had a massive variety of experience. At one end, 13 hours of ophthalmology, and it might well have been one of the opticians that was in LOT might have had 13 years or more of experience. And that was quite useful, and I'll tell you why in a second. So again, the outcomes of the algorithm were not, as you'll see in a minute, central retinal vein occlusion. They were basically which bit of the eye? Retina, macula, optic nerve. So the algorithm correctly diagnosed retina in 71% of the cases, macula in 86%, and so on. You'll be able to see the slide that I'm narrating here. Again, very useful from my point of view was the accuracy of the diagnosis was very similar for each of the algorithm users, with only a spread between 81% with Cameron, the medical student, up to 92% the experienced optometrists. Now that's quite useful because if, for instance, the algorithm was very much experience dependent, you'd imagine that Cameron, the medical student's diagnostic accuracy would be way less than the much more experienced optometrist, so that was quite good. So just coming on to the visual loss algorithm here, and we can see right at the start, you might be a little bit surprised saying, oh, well, it's not visual acuity. the key thing and the key step is doing a confrontational visual field test to try and initially place if the lesion is in the posterior visual pathways because the field defect is bilateral, affecting both eyes, or if it's a monocular field defect affecting the anterior visual pathway. So what we mean by the posterior visual pathway is the optic chiasm, the optic tracts and the optic radiations. The anterior visual pathways is basically anything right from the very front of the eye, such as a corneal opacity, right through to the optic nerve. So again, if you want to get ophthalmologists excited and animated, then ask them to teach somebody about how to do a confrontational visual field. They get very agitated that they must do it their way. I've got a way that seems to work for me. It's described in the GP's ophthalmology tutor book in the examination section, but it really doesn't matter which way you do it as long as you can pick up the field defect. And again, we have to be realistic. If you're doing a visual field confrontation, even an experienced person, for instance like myself doing it, what I'm trying to do is, for instance, if I'm checking my, not that I'll be doing my own visual field, but I'm demonstrating with my own visual field, what you're really trying to say is the visual field central? And again, that will be reflected in the visual acuity being down. But then also the first step I say is when the patient's got one eye covered, I say, do you see my face? Do you see all of my face? Some patients might say, well, I can see the right half of your face, not the left half. That could be the start of picking up a homonymous field defect. Equally, they might say, well, I can see the upper half of your face, not the lower half of your face. That's quite useful because, for instance, patients may have an upper hemicentral artery occlusion, central retinal artery occlusion, or some pathology that's affecting the upper pole of the optic nerve, and then they would have a lower field defect. So after you've said, do you see all my face, and you're moving your hands, at that point in time, what you're really trying to do is to place the patient's visual field defect into 1, 2, 3, or 4 quadrants. So let's say the patient's got a problem on both eyes, then it's to do with the pattern of the field loss. If the field loss is what we call homonymous, it's on the same side. So for instance, if I'm the patient and I've lost the right half of my visual field of my right eye, and I've lost the right half of the visual field of my left eye, how we describe that defect is, it's the right half of the right visual field, it's the right half of the left visual field, so it's a right, same side on both sides, homonymous, and because I've lost half of it, it's a hemianopia. So if you've got a homonymous defect, whether it's right or left, then what we're talking about is obviously a posterior visual pathway lesion, and it's after the chiasm. And if it's on the right side, the visual field defect, it's on the left half of the brain. Your visual system respects the same rules as the rest of your neurological system. The left half of the brain controls the right half of the body and vice versa. If, however, your field defect affecting both sides is bitemporal, in other words, it's affecting the temporal field, the right half of the right eye, and the temporal field, the left half of the left eye, so the field defect's here, then that points quite firmly to the optic chiasm. And again, if you have a patient referred in, and we triage referrals that come in, and if the opticians, whether or not they've made the diagnosis, if they attach a set of fields to a patient and they're referring them along for unexplained field loss, and the patient's got a bitemporal field loss, then if it's a nice, reliable, repeatable field, then as a clinician, there's no point in me bringing the patient in, seeing them in the clinic, repeating the fields, having the same field defect, and then sending them for the important test, which is imaging the visual pathways. What I would do is image the visual pathways before I see the patient, and then I'll have the result when I see them at the first visit. So if we come back to the confrontational visual field, and it's a monocular field defect, then doing the visual acuity, if it's normal, then it's clearly just a problem with the peripheral retina. If the visual acuity is reduced, then the first thing to do is to do a pinhole visual acuity. If the visual acuity is normal, it's simply a refractive error. If the pinhole visual acuity is reduced, then we still have to explain why the vision's down. And the next most important thing to do is to do a swinging flashlight test looking for the presence of a relative afferent pupil defect. If there is an RAPD that's present, then the next step is to do fundoscopy. If the retina is abnormal, clearly it's a problem with the retina. If the retina is normal, it's a problem with the optic nerve. Because why would you get a relative afferent pupil defect? Well, really, it's very sensitive for optic nerve dysfunction. So if you've got an optic nerve problem, such as if, say, for instance, I had MS and demyelination and an optic neuropathy on this eye, then I could have 6/6 vision in this eye, 6/9 vision in this eye, and despite only having a relatively small difference in the visual acuity, I'll have an absolute whopper of an RAPD. So when I'm doing the swinging flashlight test and the rhythm is 1, 2, 3, 1, 2, 3. So in other words, you come across between the eyes as fast as you can, and it's the initial reaction of the pupils. You want a nice dark room so the pupils got a nice large resting size. You don't want the patient to look at you or your light source. They'll get a near response and a wee pupil. So it's a darkish room. The patient's looking into the distance. You've got a decent light and you go as quick as you can between the two sides, and it's the initial reaction of the pupil. So if when you swing the light into this eye with the optic neuritis, then the pupil will paradoxically dilate, and this dilation is what we call a relative afferent pupil defect. So it's very sensitive for optic nerve disease. You can have quite subtle difference in the visual acuities, but you'll have a good going RAPD. Because your optic nerve is composed of retinal ganglion cell axons, if you've got something wrong with about a third or more of the retina, then clearly you will have an RAPD. Importantly, what doesn't give you an RAPD? Well, you could have the world's densest cataract, 6/5 perception of light, no RAPD. Why not? Because the light diffuses through the cataract. You could have the world's worst macular degeneration, 6/5 hand movements, no RAPD. Why not? Because the macula is only the central 10% of the retina, hence no RAPD. Now you'll know that already. Why? Because you'll have done a visual field to confrontation, and then the eye with the RAPD, you'll have a full visual field to confrontation. So almost before you examine this patient's fundus, you've boiled down to either an optic neuropathy or a maculopathy, assuming they don't have a media opacity. How do you differentiate that before you start to look at the fundus? The presence of an RAPD. If the reduced vision is due to maculopathy, no RAPD. If the reduced vision is due to an optic neuropathy, RAPD. So that's the explanation behind this part here. Reduced visual acuity, swinging flashlight test, RAPD absent. Fundoscopy, clear retinal view, it'll be a problem with your macula. Hazy retinal view, media opacity. And again, these are evolving, these algorithms. So we've put down here media opacity, and you'll see that as being green, i.e. you don't have to refer it urgently. And one of the obvious things is that I didn't consider when I was making up the algorithm that I've taught the students for years, is if you've got a sudden onset of reduced vision, then that's very likely to be a vitreous hemorrhage, which actually would be an urgent referral. Whereas if the patient's had a gradual, painless loss of vision, then almost certainly it's going to be, the media opacity is going to be a cataract, which isn't an urgent referral. And again, the next version of the algorithms will have a wee annotation for that. So coming on to the last one, the double vision algorithm. Now again, this is data that's still out at the reviewers. Hopefully the reviewers will be happy and they'll publish it, but that still remains to be seen. So this is really giving you, if you like, a bit of a preview of what is in the paper here. So this isn't published yet. The double vision one, if anything, this is actually the most impressive results of the three in terms of an algorithm naive inexperienced observer, and then using the algorithm with a significant improvement. And you can see here that patients presenting with double vision, the pre-algorithm diagnostic accuracy was at 24%, whereas afterwards the improves to quite an impressive 86%. And again, same sort of story with the design of this study. We had individuals such as GPs, optometrists, A&E doctors referring patients into the acute referral centre with patients presenting with double vision. And we would see what their diagnosis was, and we would record that. And on the same patient, again, some inexperienced observers. The observers this time were Tim, a fifth-year medical student, and Laura Butler, who was an FY2, who hadn't had any ophthalmology experience, but I'm glad to say Laura's now been recruited to the fold, and Laura's an ST1 in Glasgow. Those were the two inexperienced observers. So Tim had, again, just like Cameron in the previous study, 13 hours of ophthalmology in the previous year. Laura hadn't had any postgraduate teaching in ophthalmology, so very inexperienced observers. So what would happen is the patient would come in, Laura or Tim, mostly Laura, would then see the patient, come to an algorithm-assisted diagnosis, and then the patient would then be seen in the clinic by a consultant only. And again, why you might say, well, you've changed the standard. In the last one you did an ST3 or above. Why didn't you pick an ST3 or above for this one? And it just reflects that if there's one subject in ophthalmology that I think is probably not taught at all well, is double vision. And when we were discussing what should be the gold standard, not many people would be happy with a diagnosis of anyone other than a consultant seeing the patient for double vision. And that just reflects the fact that maybe it's not as well taught as it might be, although hopefully with the algorithms it will be better taught. So how did we get on? How did Laura and Tim get on with the algorithm? So the endpoints are, we'll see in the algorithm, again, it could be a cranial nerve palsy, an internuclear ophthalmoplegia, etc. When we look at, because sometimes the most useful thing is looking at your failures to say, well, where did the algorithm get it wrong? I'd alluded in the red eye talk that perhaps we didn't give enough weighting to using magnified illumination when you're looking at a wee structure such as the cornea. We didn't get it right with the algorithm-assisted diagnosis for the double vision for a number of cases. And if you can break down the wrong diagnosis, the wrong algorithm-assisted diagnosis into really two categories: problems with the algorithm themselves and problems with the person using the algorithm. And algorithms are really always a bit of a compromise between having enough detail and enough conditions to make them useful, whereas not making them so unwieldy that, for instance, people get put off because they just look too complicated. So they're always a balance between having enough detail but not being off-putting. So for instance, one of the incorrect diagnoses was myasthenia gravis, which is a notoriously difficult thing to diagnose anyway. The algorithm diagnosed that affective is a third nerve palsy. So we weren't unhappy with that. Again, two of the other wrong diagnoses were, as you'll see in parentheses there, is HZO-related double vision and post-head injury double vision. Now, those were patients that were seen by a consultant that wasn't a squint specialist, and in all honesty, if you spoke to somebody who was a squint expert, they wouldn't accept either of those two diagnoses as being a real diagnosis. For instance, the post-head injury double vision, the algorithm recorded that as a fourth nerve palsy. And in all honesty, that was probably the correct diagnosis. As often in closed head injuries, a fourth nerve palsy is the most likely thing. And often, as happened with this patient, their double vision got better. But because even though it was a consultant that wasn't an expert in squint made that diagnosis, we had it down as a wrong one. So if anything, we've been a wee bit over hard on ourselves there, but I'd sooner be that way round. So just going through the double vision algorithm here. The first thing to clarify is, with a patient is it actually double vision, two separate images, or is it blurred vision, one blurred single image? Because we all know what we're talking about when we're talking about double vision. We know that it's two separate images, but patients don't have any medical background, and sometimes they can use it interchangeably. So something simple like that, if you don't clarify that right at the start, you could be then looking at a patient for the next 20 minutes trying to pick up some subtle eye movement problem and getting more and more harassed because you can't see it. But actually, it's not, you can't see it because it's not there, because actually the patient's simply complaining of blurred vision. So if we go here, if they say, no, actually, I mean, doctor, it's one blurred image, then immediately you can go back to the visual loss algorithm. Assuming that it is true double vision, two separate images, the next thing which is crucial, and it isn't always stated, is, does the double vision go with each eye covered separately? So for instance, if the patient says with one eye covered, whichever eye, the left eye or the right eye, they say, no, I still see two images, then what they're really describing is monocular double vision. And monocular double vision nearly always represents cataract, just down this little bit of the algorithm here. what we mean by a cortical abnormality is that not always can you get a good explanation for some things in medicine, and monocular double vision, essentially the only treatable cause of monocular double vision is cataract. You can get some incredibly rare causes with real problems with your retina, or very occasionally I had a patient recently who had had refractive keratotomies, the old-fashioned way of reducing your myopia with little radial cuts being made in the cornea, and that patient was well aware that she had monocular double vision of each eye separately. So rarely it's a corneal cause, rarely it's a retinal cause. The vast majority of treatable causes are cataract, and like everything in medicine, there is a cohort of patients that have monocular double vision, often bilateral monocular double vision, that you just have to put your hands up and say, I'm terribly sorry, I don't know what's wrong, but I'm sorry, there's nothing we can do, because the only treatable thing would be your cornea, your retina, or your cataract. So coming back to the algorithm here, so here we are on double vision still present with each eye covered separately? No. So what we're now talking about is what everyone assumes is binocular double vision. In other words, a problem with the eyes not being aligned properly. And the next simple question to ask the patient is, how are the two images separated, if it's horizontally or vertically? And again, here's another wee thing that I have to change with the algorithm. When I've said horizontal here, what I should say here, and I will later, is pure horizontal double vision. So in other words, you say to the patient, with your two images, are they side by side, or to some degree are they one above the other? And if the patient says the images are purely side by side, then that's what I mean by horizontal double vision. And then all you would really want to do is to ask the patient to look to the side that makes their double vision worse. So for instance, they say, okay, my double vision's worse when I look to the left. Then that's fine. You would just get the patient to look to the left, and simple observation, you just look to see what's happening. If when the patient looks into the field with their double vision's the worst, say to the left, if when they look to the left the eyes converge, then effectively that's a sixth nerve palsy. Why? Because if I've got a left sixth nerve palsy, my double vision will be worse when I look to the left. So when I try to look to the left, what happens is my right medial rectus adducts over this way, my left lateral rectus cannot adduct, therefore my eyes are probably reasonably parallel if it's a mild palsy, but when I look to the left, what happens is this eye comes over, but this eye can't move over. So therefore the eyes effectively come together, they converge. Similarly, if the double vision is worse to the left and I look to the left, and what happens is the eyes don't converge but they diverge, then that could be a problem relating to what we call an internuclear ophthalmoplegia. And essentially, why do the eyes diverge? You've got normal abduction of the left eye, but you've got reduced adduction of the right eye. So when the right eye then moves, when you look to the left eye moves over, but the right eye doesn't move. So what happens to the angle of the eye is they look into the side with more double vision, the eyes diverge. Nice and simple. Again, if we come back to how are the two images separated, and they say vertical. Now, when we mean vertical, what we mean is vertical or oblique. In other words, anything that's not purely horizontal. Most people with vertical double vision will say the images are a wee bit obliquely separated. Very rarely is it completely one above the other. So if there's an element of double vision vertically, then the simple observation is there an isochoria, difference in the pupil sizes, or ptosis present? And if there's an isochoria or ptosis present, what we're thinking about is a third nerve palsy. Why? Because when you think of the innervation of the 6 extraocular muscles, 4 out of the 6 are innervated by the third cranial nerve, everything except the lateral rectus, the 6th cranial nerve, and the superior oblique, which is the muscle you use when to depress the eye when the eye is looking down. So the superior oblique problems, patients will usually say, I have more double vision for reading. Why? Because that's the muscle you use to depress the eye when you're reading, and it's worse for going downstairs. Why? That's because you tend to look down when you're going downstairs. So if you've got a third nerve palsy, you'll have an eye that's usually to some degree down and out. Why? Because the only two muscles that are still working are the superior oblique down and out the lateral rectus. And nearly always patients with a third nerve palsy will have an isochoria with the affected side of the pupil larger, and to some degree often they'll have a degree of ptosis. Why? Because the other function of the third cranial nerve is that innervates the levator muscle. So hence, if you've got true binocular double vision, it's vertically separated to some degree with ptosis or anisocoria, it's a third nerve palsy. If you've got true binocular double vision, vertically separated, and anisocoria or ptosis absent, the next thing to look at is, does the patient have signs of thyroid orbitopathy present? And there's some well-recognised signs of thyroid orbitopathy, such as a little bit of proptosis, the eyeball coming forward, and a little bit of eyelid retraction, upper or lower lid, often the upper lid, often a little bit of lid lag. So when you look down, the eye is affected, the lids don't come down as well, so it lags up. And often it can be a little bit asymmetrical. Again, the patient might say, yes, I've got an overactive thyroid, and they may have a goiter, a lump in their neck. So often a bit of the history as well as just the examination findings will alert you to the fact there could well be some element of thyroid orbitopathy present. And last of all, for instance, if the patient has binocular double vision, they're vertically separated, the images, the anisocoria or ptosis is absent, and there's no signs of thyroid orbitopathy, then they'll very likely have a fourth nerve palsy. When I started off doing squints a wee while ago, I used to find fourth nerve palsy diagnosis extremely difficult, because if you look at the patient, very often there's a very subtle difference between the height of the eyes, and it involves doing a cover test and then doing a head tilting test. And once you've got the hang of those things, you know, you wouldn't use the algorithm to diagnose a fourth nerve palsy or confirm it. You would probably use it to diagnose it, but to confirm it, you'd do the cover test and the head tilting test. But until you've got the hang of the cover test and the head tilting test, this, I would suggest, is a much more reliable way of diagnosing a fourth nerve palsy. Just in conclusion, these little algorithms, and we hope you find them useful. I think the main benefit was that that's the first time they've been subjected to a little bit of scientific analysis. There's lots of algorithms out there, but ours are the first that we've actually, if you like, put to the test. Good. So anyway, hope you find that useful, and good luck in your study.